Dr. Tessler. Dr. Wall's famous 5-star study guide has been around for quite a while, 30 years plus. Don't worry, we've updated it, but this is one of the most sought after study materials for board preparation. If there's anyone who knows the boards, it's Dr. Wall and those that he's trained. So join us for a review of Dr. Wall's famous 5-star study guide. And remember, all items from Obgyn Board Prep are trademarked and copyrighted, meaning they cannot be redistributed or copied in any way. Let's head into the book and flip over to your first section, obstetrics. On this page, you can see Rh antigens, which are important to know. Now, I would pay attention to those things that do not cause and those things that do cause hemolytic disease. I'll tell you a trick with these. See those superscripts on Duffy? If it's Duffy with a superscript B, that's better, so that kid lives. If it's Duffy with a superscript A, that's awful. Those kids die, unfortunately. So if you have one of these complex looking Rh, it doesn't have to be Duffy, but it has all these other letters after it. Try to find that superscript. If it's superscript B, it's usually better. If it's superscript A, it's usually awful. Remember, there's no lowercase d Rh antigen. There is tons of antigens, but that's not one of them. Nuchal translucency should be completed between 11 weeks to 13 weeks and 6 days. That timing is important because it can make it a correct or wrong answer based on when it was completed. Greater than 3 millimeters is the measurement that you want to know because greater than that does warrant further evaluation. This is looking usually for Down syndrome or neural tube-like defects that can be caused from this, but I importantly want you to know that this is also related to congenital heart disease or cardiac malformations, and that is usually what happens when there's an abnormal nuchal translucency, but a normal karyotype. Aneuploidy risk by maternal age is understanding how to predict the results for someone by age of their risk of Down syndrome or any other chromosomal abnormality. Fetal circulation is outlined here in a simple diagram flow for you. Make sure you know the different parts of the fetal circulation, including those things that are pertinent only in the fetus, like the ductus venosus, ductus arteriosus, and the foramen ovale. At the bottom of the page, you see placental crossing. Knowing which things do cross and don't cross the placenta is very important, and knowing those things that cross in certain ways. For example, facilitated diffusion is your simple sugars. So remember fructose, facilitated, F and F. Then the other simple sugars are glucose and sucrose. Simple diffusion is important because that's your oxygen, your CO2, electrolytes, ketones, and I'll tell you also in that category is alcohol. Umbilical cord gases, this is from your Obgyn Illustrated, but I'll tell you the most important part that you're going to need to make sure you understand how to read those labs. This is going to be the 20, 30, 40, 50 rule. This rule shows you that the two numbers on the outside are going to be arterial numbers. So there's 2 arteries, so it spreads around the venous in the middle and creates 2 prongs of O2 and CO2. I always think of O2 being more important than CO2, but whatever works for you. But the O2 numbers are first and the CO2 numbers are second. So if you can remember, the arterials go around the outside and both of the OTs come first, reading left from right, and the CO2s come last, you can remember what assigns to 20, 30, 40, and 50. This is going to be an important tip for you. If the arterial O2 is above 38, that means something was wrong with the sample. It's most likely a venous draw, or there was air in the sample because it should not be that high. Iron requirements in pregnancy can be a little confusing. We've created the ironclad summary, and you're going to probably have to still sit with it, but I'm going to walk you through it. It does make sense. 4 milligrams per day of iron is the requirement in pregnancy. 4 milligrams per day times approximately 250 days of a pregnancy is 1,000 milligrams. So 1,000 milligrams of iron required for an entire pregnancy is what's needed. That's 800 milligrams additional iron requirement in pregnancy. So where do we come up with that? Let's look at the left side under iron requirements in pregnancy. The last 133 days or last half of pregnancy is going to be 1,000 milligrams. The fetus and placenta are going to take up about 300 milligrams. The increased maternal hemoglobin is going to use up about 500 milligrams. And insensible loss of shedding from like the skin or the GI system is about 200 milligrams. So 500 plus 300 plus 200 is 1,000. That's why we get the number for 1,000 needed. So this is an 800 milligram increase from normal steady state. So otherwise, 200 is our normal steady state need for iron. This is an 800 milligram increase over, so therefore it's 1,000 milligrams total for the entire pregnancy. From each 325 milligram ferrous sulfate in the oral preparation, remember, 20% elemental iron is all you're going to get, which is 65 milligrams. 10% of that elemental iron absorbed, so you're only going to get 6.5 milligrams of that. And remember, studies show that giving it more than one time a day really isn't beneficial, and also giving it with all these different things is also not beneficial, but citric acid still seems to be a good thing to give it with. Physiologic changes in pregnancy, you just have to understand these and know them. Something that I'll go over on this page is down at the bottom, and that's pulmonary changes in pregnancy. We've come up with these little sayings to help you remember some of the things that go up and down in pulmonary changes in pregnancy. In the decrease category, we have RV, ERV, TLC, and FRC. We created the saying, take the RV down to the ER for some TLC because it's free. This is to remind you of that residual volume, that expiratory reserve volume, that total lung capacity, and functional residual capacity go down in pregnancy. Now, increasing in pregnancy is IC, TV. So I see the TV. Think about those hospital rooms where you have to look up into the corner to see that TV hung from the ceiling. So you have to look up to see the TV. I see the TV up. So those are going to increase in pregnancy. Now that's your inspiratory capacity and your tidal volume. So tidal volume and inspiratory capacity go up. No change in pregnancy is going to be inspiratory reserve volume and your vital capacity. I just think vital capacity is vital to remain the same. Thyroid changes in pregnancy are really important to understand because this is a process that's driven by beta-HCG. Beta-HCG is rising in the early pregnancy at an exponential rate up to about 100,000 or so. The 100,000 is about 10 to 12 weeks. That's also when the fetal thyroid comes online and starts producing its own thyroid hormones. Until that time, it's supported by the excess free T4 that is present in the maternal circulation because beta-HCG has an alpha subunit like TSH, allowing it to interact with its receptors. However, TSH recognizes and goes down because the TRH and the hypothalamus say, wait a minute, that's a lot of T4 around here. Let's shut down our TSH, which results in a euthyroid state. Pelvimetry and anatomy of the reproductive tract. Pelvimetry is not as big of a thing as it was once upon a time. However, it's important to know measurements and just be aware of these as different things that can kind of restrict your possible pregnancy delivery. Remember that the diagonal conjugate is what you can actually measure internally on a patient. The next one is the obstetric conjugate, which is the actual smallest part of the birthing canal. The obstetric conjugate is 1.5 minus from the diagonal conjugate. This is also the fact that the true conjugate is equal to the diagonal conjugate. But remember that obstetric conjugate is what's important because that's going to be the smallest part that that kid has to pass its head through or whatever it's sending down first. Term measurements of the biparietal diameter are about 9.3 centimeters. So remember, that's a big part of the head. And if that's at 9.3, you don't have much room to make if you're talking about the normal measurements of the obstetric conjugate. Now remember, crown rump length plus 6.5 centimeters always equals the week of gestation. It's kind of a cool little way to find the answer and to show off that you know what the crown rump length equals. Caldwell-Malloy was a classification of pelvic shapes. Some of the things I can tell you that are important from these is anthropoid has the letters OP in it, and it does increase OP deliveries to have that shape. Now, android is the male pelvis or the bad delivery shape. because there's the least transverse diameter of outlet. Platyploid is a flat oval and it's persistent transverse. So I think of a platypus with its bill like a duck, and that's nice and flat. And that's going to be the persistent transverse position of platyploid. Embryonic development and fetal development are important high-yield facts. You must understand what's 2N, what's NN, 1N, when things are fertilized, and when things are happening throughout the process. I will tell you at 32 cells plus at blastocyst, this is when most IVF procedures are occurring. Twins is important to understand when certain things happen in correlation with timing. Like 0 to 3 days can be a diamniotic or dichorionic, or a fused diamniotic dichorionic, which results from a monozygous pregnancy. Monozygous are the only things that really persist onward, and that's going to be diamniotic and monochorionic, mono, and conjoined. On the bottom of this page, you're seeing TTS and TAPS. A lot of people asked for this over and over again. They wanted a way to figure out what was TTS and what was TAPS. If you follow this algorithm, you're looking first and foremost, is it a monochorionic? If it is, then you can proceed forward. Gestational age delivery for monochorionics is between 34 and 37 and 6. I don't know anybody that goes to that long end, but okay. Now, if we're going to gestational age less than 34 in a monochorionic pregnancy, then we're going to keep them pregnant and we're going to try to figure out what's going on. This is going to deal with the MVP. If the MVP is greater than 8 and or less than 2, then that's TTTS. So twin-to-twin transfusion syndrome is correlated with that Ali-Poly. That Ali-Poly is going to lead you to the understanding that it's TTTS, as that's one of that is the first stage of Quintero staging. If that's not the problem, keep heading down the algorithm. Next, you're going to look at estimated fetal weights. If it's less than the 10th percentile, growth discordance is 25% or greater, that's going to be selective fetal growth restriction. If it's not, you're going to jump on that ultrasound again and you're going to look at those MCAs. If it's greater than 1.5 and less than 1.0, either or, then that's going to be TAPS. Mortality and risk in pregnancy, there's some things that you should definitely know here. Some high risk things are definitely pulmonary hypertension. That's in group 3 mortality. Eisenmenger syndrome is another one of those. Remember, that's a congenital heart defect that wasn't fixed or didn't fix completely. And then the shunt switches and it causes problems later in life. Postpartum hemorrhage, remember the definitions for these have equaled out. And it's 1,000 milliliters in the first 24 hours following delivery. And if it's delayed, that's beyond 24 hours following delivery. The reasons for those tend to be different. Birth to the first 24 hours is atony, and still atony. After that, it's more likely to be something like retained products or infections or subinvolution of placental site. Causes of maternal death, the number one is cardiovascular. Make sure you understand it's cardiovascular. Peripartum cardiomyopathy, there's some buzzwords that I'd want you to know. Those are things like soluble FMS-like tyrosine kinase, oxidative stress, or impaired VEGF signaling. We used to think it had a lot to do with prolactin, but we know it's not as connected to that now. And we actually let these patients breastfeed where we really didn't encourage that before because of prolactin association. The hallmark finding to this is cardiomegaly and an ejection fraction less than 45%. Fetal abnormalities in genetics. It's important to know what's autosomal dominant, what's recessive, and I also want to point out this category. That's an uncommon one to think about, but they're very important things because they're multifactorial. That's going to be things like neural tube defects, spina bifida, congenital heart diseases, Müllerian agenesis, and endometriosis. That's right, endometriosis is a multifactorial inherited issue. Next, we're going to take you through some of the trisomies and other abnormalities of genetics. Trisomy 18 is one that is less than 10% survive to the first year, but can be born alive. Trisomy 13 is Patau syndrome, and that's less than 3% survive to 3 years. So again, can be born alive and live some time frame. 5P or Cry du Chat is a high-pitched cry cat cry born alive There's an epicanthal fold and a mental retardation that's associated with this pathology. Turner syndrome has Turner stigmata. This is less than 10% survive to 1 year in severe forms. However, we see a variance of Turners showing up. Short stature, wide-spaced nipples, streaked gonads, webbed neck, and the Omar's walk or increased carrying walk are some of the most common things that you see along with Turner stigmata. Remember, there's other things that happen with these patients like renal anomalies, coarctation of the aorta, and also they can have trouble hearing and have a high arched palate. This is breaking down genetics for you. Take a look at it, but the one I'm going to point out to you is remember, if there's a specific gender being asked about, you got to split that answer down by another half and take it to the specific gender. MSAFP, maternal serum alpha-fetoprotein, has been found to be connected to many, 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 many things. But these are some of the most important things that we see high MSAFP and low MSAFP pointing to. It's important to understand that fetal death is on both sides of high and low. That's also why it's not a good tumor marker, because in pregnancy, high and low concentrations can mean different things, and that's related to the pregnancy, not to another process. Cystic hygromas are lymphatic lesions. They're very commonly associated with Turner syndrome, but also can be fetal hydrops or Noonan syndrome. Diabetes in pregnancy. You got to remember how to break down your calories, and that's important. I like to use better rounded numbers like 30. So 30% for breakfast, 30% for lunch, and 30% for dinner. 25 is fine too, but it just helps me to remember. Now, evening bedtime snacks are half of that, which is 15. So like I said, easier numbers to break down. I do the same thing with my calorie breakdown over here for my macronutrients. Protein 30, carbohydrates 30, and fat 30. As you can see, it rolls into those numbers pretty well. Now remember, your carbohydrates should be complex carbs and your fats should be unsaturated. Below, you're going to find how you break down your insulin for a pregnancy. Now, I'll warn you, some people learn this differently in their residency teaching models. However, you need to know the basic way that the American Diabetes Association, SMFM, and ACOG endorses. That's going to be the one that we've reflected here. So make sure you can do the math the way that it needs to be done, and you follow the trimester multipliers correctly. Fetal weight. Here's some important things that I would definitely know. At 20 weeks or so, remember, you're around 300. By 24-ish, you're going to be closer to that 500 point, which is much more of a safer, better chance for viability number. 28 is 1,000. That's a good one to lock in. Just remember it. After that, you get to 32, which is 1,600. 1,600 is half of 32, so it's an easy way to remember it. But remember, that's not exactly a normal kid at 32 weeks. That's a 10th percentile kid. So you want to make sure that you know that 1,600 is a little 32 weaker, but it's an easy number to remember because it's half of 32. Another important thing that happens at 32 weeks is the understanding that the head and the waist become equal. So again, at 32 weeks, the head circumference and the abdominal circumference are equal. Before that, the head is much, much bigger. So that's the problem with preterm kids before 28 weeks and such, and why a C-section is a much better choice, because their heads are huge and they're usually breech or transverse and they'll get stuck. And you don't want a preterm kid with not a lot of reserve getting stuck. At 32 weeks, they become equal. And then after that, for the rest of our lives, our abdomen's usually bigger than our head circumference. Now, 34 weeks is 2,000. Again, nice round number to remember. 28,000, 34 is 2,000. And after that, it's super easy. 250 grams every week after, or 500 grams every 2 weeks. Cardinal movements of labor. Let me tell you a little story to remember it. We all enjoy like Hallmark and romance movies around the holidays, right? Or we at least know someone that does, and they hog the TV remote. So you know that even in these small towns where no one hardly lives, they all seem to have a cathedral where they get married. So at the cathedral, you've got that big, beautiful steps in front, the big giant doors that they come through right after the marriage and run down. Let's have that scene in our head. So first you have to get engaged, right? So when the heroine of the story figures out that the guy's actually a millionaire, they get married. But they got to get engaged first. They get engaged, they go get married. Then they bust open those doors on the front of the cathedral and they descend down the steps. As they're descending down the steps, people start to throw rice at them or some biodegradable material that doesn't hurt birds. When they're doing that, they flex their heads down because they're throwing rice at them to not get it in their eyes and mouth. And then they turn into each other, internally rotate to each other to protect each other from the rice throwing. And they run down the rest of the stairs. And then one of them will extend their arm out to the limo to grab the door handle. So they're going to extend their arm out and then turn externally to grab that door handle and pull the door. And then they're going to expulse out of there in their limo and live happily ever after. So that's my Hallmark story to get you through the cardinal movements of labor. And the reason we do it that way is because some of the sayings about the eggs and darn fools and all that, it's great to give you the order, but then there's a lot of E's and a lot of F's and a lot of other things going on. So you don't remember which one's which. Oocytes by age, just remember when you're born, you're 1 in a million. So that helps you remember what you have at birth. By puberty, that's cut in half. And then by age 50, you're down to 1,000. Bishop pre-labor scoring system is something that you just have to know. I'll help you out with some easy things to basically figure it out. DES, like diethylstilbestrol, related to clear cell vaginal carcinoma. That's dilation, effacement, and station. There's 3 things in DES, so they all get up to 3 for a score. Consistency in position, like cerebral palsy, reminds us that there's only 2 of them, so they only get up to a 2 maximal score. All categories have that max score of 3 except consistency in position. Now, the Bishop score is helping you predict the success of inducing labor, and a low, less than or equal to 5, is unfavorable. Higher Bishop score, greater than or equal to 9, is highly favorable. Some books have that at 6, some books have it at 8, but everybody will agree 5 or less is not a good situation. The maximum score is 13. APGAR scores, just tell the story of a birth. It'll help you out. Remember, you get the kid in your hands. You want to make sure they're active or they at least have some tone, right? Then you're going to pass it up to that nurse and they're going to start seeing the appearance and the color as you pass them up because they're going to start getting a little pink. So that was your part. And then the nurse is going to start doing pulse and respirations and make sure those are okay. And then the mom wants to see a grimace. So that's mom's part. And the best of the grimace, which is the sneeze. So if baby gives a little sneeze, everybody goes, "Aw." The birth palsies. Talking about these is pretty straightforward. We have Erb's and we have Klumpke. Erb's palsy is from yanking that head far away from the brachial plexus. So pulling that head way away from the brachial plexus creates strain on the brachial plexus upper portion, which is C5, C6 nerve roots. This is going to cause the waiter tip, which is going to be a turned arm to the back with the hand out behind them looking for a tip. Klumpke palsy is a lower arm palsy, and this is actually from the arm being extended upward away from the torso and has nothing to do with the neck. This is going to pull on the brachial plexus in the lower portion, and this is going to cause a C8 to T1 nerve root injury. So I like to think of this one as somebody falling out of a tree, and then they reach up quickly as they're falling and they grab a branch, and as that tension goes snapping upwards, it puts all that pull onto the brachial plexus in the lower portion, and it causes that palsy, Klumpke palsy, which causes the claw hand. There's a list of things that go along with vacuums. As we know, vacuums are more likely to be a neonate problem than a maternal problem as far as injuries. C-section rates are important to understand, both because we need to reduce them as much as possible, but also you should be able to calculate your own. When you're done with this little written quiz, you're going to go take an oral quiz, and that oral quiz, you need to be able to know and tell your C-section rate and what it comes from. Acquired thrombophilias and inherited thrombophilias, you must know the difference between the two. So acquired are things like systemic lupus erythematosus, antiphospholipid syndrome, anticardiolipin, and paroxysmal nocturnal hemoglobinuria. The other ones are things that are like protein CNS, prothrombin G, antithrombin 3, and hyperhomocystinemia. Factor V Leiden has both a heterozygous and a homozygous form. Factor V Leiden by far is the most common. All I would take from here right away is radiation. Radiation is important to understand that it can be given in raids or grays, but most of us do them in grays now. The lowest dose exposure in a pregnancy is going to be a chest x-ray. So not as big of a deal. And then the highest dose would be a CT, abdomen, pelvis. Infections in pregnancy, let's just point out some really important things to remember. Rubella is definitely the most teratogenic of all of the infections. When you have parvovirus, I want you to remember mirror syndrome. That's going to be the slap cheek, reticular rash, but then the pregnancy itself mirrors what's happening on into the pregnancy of the fetus and what's going on with them. So we get preeclampsia, anemia and swelling in the patient or the mother, and the fetus is going to have a lethal problem, which is stillbirth, hydrops, and abortion. So rubella is the most teratogenic. Parvovirus is the most lethal. Now, the most common, hey, it's a C, that's helpful, is cytomegalovirus. Cytomegalovirus is mononucleosis symptoms, and it's worst if contracted in the first trimester. When it comes to cytomegalovirus and toxoplasmosis, let's talk quickly about those scans inside that kid's head. When you're doing these scans, you're most likely to see concentric Cs inside cytomegalovirus. That's periventricle calcifications for cytomegalovirus. Now, when you're talking about the scans in toxoplasmosis, who do we blame for toxoplasmosis in the US? Kitty cats. Kitty cats get this blamed on them, even though most of them do not carry it. If they do carry it, it's not most of their lifetime, but it is in their fecal waste if it is there. And that's why we tell people to try to get somebody else to change that waste, or if they do it, to dress like they're going into a nuclear meltdown. When we're talking about toxoplasmosis, we're talking about those kitty cats, even though the rest of the world, toxoplasmosis is usually caused by undercooked meats or unprepared foods. And that's how the cats get it, because they eat mice and birds and undercooked things, or just literally cooked by the sun that day. So toxoplasmosis, kitty cats, what do kitty cats do when they go in their litter box? They don't do concentric Cs. They put poo in the litter everywhere. So the calcifications in toxoplasmosis look like a litter box. It's just all over the place, intracranial calcifications. Treatment of toxoplasmosis is also very interesting. You actually have to contact the FDA to get spiramycin for the treatment. Varicella is highly contagious, and there's a 30% mortality with the pneumonia related to varicella, which the pregnant patient can get from their immunodeficiency, or the kid can get if they contract it early on in life. If it is contracted in the second trimester, this causes congenital abnormalities such as limb hypoplasia, growth restriction, and microcephaly. If it's contracted nearer to delivery, 5 days before or 2 days after delivery, varicella pneumonia or just congenital varicella can occur, which both are very scary and have a high risk of death. If you're talking about varicella pneumonia, I want you to remember, throw the kitchen sink at it. These individuals need IVIG, they need IV acyclovir, and a lot of treatment to make sure they're okay. Eclampsia and preeclampsia, we put some flowcharts here for you to just help you with making sure you understand all the things that go along with these. This was highly requested, so we wanted to make sure we gave you as much information as possible. The next page goes into some diagnostic criteria, but I actually like this section right here. A lot of people get in trouble with the magnesium and emergency medications. I want you to know what you can do intramuscularly when you don't have an IV. I want you to know what happens when they don't take to the first bolus and you give an added bolus of things such as lorazepam. And if the magnesium is contraindicated, what do you use? A lot of people don't think about that because it's very rare. Also, magnesium labs management is very important and very high yield. Toxicity you should know as well, and contraindications. Classification of hypertension. These are definitions. You should know them. This is a great table that's been around in the 5-star study guide for a while, and it still holds true, and it's an excellent study table. Differential diagnosis of HELLP syndrome, TTP, HUS, and AFLP. HELLP syndrome has a lot of things that mimic it or look like it, but to write fair test questions about it, you've got to include certain things to make sure it's that syndrome and not HELLP. So let's take a look at those. When it comes to TTP, we came up with the concept of Twitter-pated. Now, not Twitter or X or the bird thing or whatever it is, but Twitter-pated, like they can't sit still, they're twittering, they're twiddling, they're jumping around. There's a large neuro abnormality that goes along with TTP. It's very common to it, and it's not common to really anything else in this categories. So there has to be that sign of that going on. That can also be combined with fever, which is only ever found also in hemolytic uremic syndrome. But if you have those neurological changes and a fever, you're definitely talking about TTP. Hemolytic uremic syndrome, I always think about a problem with it being about PP. Not PP, but yes, PP, but postpartum. This most commonly occurs in the postpartum patient, and that's why it gets missed initially, because our nurses are watching their urine output and things, but they're expecting some blood in it, right? They just delivered. So it gets missed for that reason. But this is a renal abnormality. There's going to be some sign of renal damage or injury taking place that's going to be much more severe than any one of these other pathologies. Now, acute fatty liver pregnancy is scary, scary. This person has a high chance of mortality, and they have to usually end up with a liver transplant if they make it to that in time. Now, hyperglycemia is the biggest thing, and I'm going to tell you it's down in this category. So that is severe hypoglycemia. Not talking like 60, 70. We're talking 50, 40, somewhere in that range. So very, very low blood sugar. That's going to be the biggest key and point for acute fatty liver pregnancy, is that clue and tip right there. Let's move into ambulatory and preventative medicine. This has become more and more high yield in the professional examination world, because often in residency, you don't see a lot of preventative medicine or office procedures or office things other than young, healthy patients who need contraception or are becoming pregnant or are pregnant. So this is more about osteoporosis. This is more about hormone management in later life. This is about other uses of contraception and hormone management. So make sure you're looking at this ambulatory and preventative medicine and making sure you understand it. Yes, unfortunately, the 5 A's and the 5 R's are something you need to know. The 5 A's of smoking cessation are ask, advise, assess, assist, and arrange. When it comes to remembering these, I came up with a little way because it's kind of helpful. So first and foremost, you always ask before you do anything or give someone advice, right? Because they may not even want it. So ask first. So after you ask somebody if you can give them your advice, you can advise them. So ask and advise. The two S's are in the middle. Well, assess is in the middle, and then followed also by another ASS word. So they're in alphabetical order to help you out. ASSE, ASSI. And then what do we do at the end of every visit? We arrange for follow-up. So that's easy to remember. You're never going to forget the order now, and you've got them down, so don't spend too much time on that. Now let's talk about the 5 R's. Never found a good way. Nobody I know has found a good way. Lots of people have told me their way, but it doesn't work for many people. So if you got one, you can let me know. However, you need to know relevance, risk, rewards, roadblocks, and repetition. It's very easy to put other words that sound like or kind of contribute to these kinds of things, but aren't these 5 specific words. You have to know these, because what usually happens if I write a test question, I'm just going to take one of these, replace it with something that's wrong, and ask you which one is not one of the 5 R's. When screening for alcoholism, eye opener is in every one of the screening methods, and it's also the most ominous. This means you have to have a drink when you wake up first thing in the morning to be able to be okay. Originally, the CAGE screener was made for men, and this was cut down, annoyed, guilty, and eye opener. Cut down is, have you tried to cut down your drinking? Or do you feel that you need to cut down your drinking? Annoyed, are you annoyed with people talking about or asking you or accusing you of your alcohol usage problems? Guilty is, do you feel bad about it? Have you missed out on things? Have you been mean to your family? Have you taken money from your family to spend on more alcohol? Eye opener, again, is, do you need alcohol to wake up for the day and get moving? Women, we originally designed TACE. So TACE is tolerance, annoyed, cut down, and eye opener. So the big one that changed here is C for cut down and T for tolerance. Pregnancy had tweak designed for it. Tweak is tolerance, worried, eye opener, amnesia, and K for cut down. I tell you, these little mnemonics get a little bit far. But remember, A is not for annoyed. It's for amnesia or blackouts. Binge drinking in pregnancy to the point where someone blacks out, or just drinking to the point of blacking out, has a high correlation with fetal death. So we need to make sure we understand if that patient's just drinking or drinking a whole lot. So amnesia and blackouts are a sign of that extreme drinking in pregnancy. So annoyed's not there. And all I think is, you're not going to ask a pregnant woman if she's annoyed. She is. Don't ask her. Just know that it's for amnesia and blackouts. The WHI study, some important things to know. This study was really, really crazy done. We gave hormone to people that we would never give it to anymore and know that we wouldn't give it to, like patients in their late 60s and 70s. The study was stopped because there was way too much happening that was bad, like strokes and heart attacks and clots. Now, we had a lot of results from the study, and if you look in the Obgyn Illustrated Guide, it'll tell you a great way to remember those things, and also when we walk through it, when you watch that video. However, results from this were really important to point out that we know that estrogen has a great effect on fractures of the bone, making them less likely to occur, and also colon cancer goes down with estrogen therapy. Blood types, most common, least common, universal donor and universal recipient are there for you. I would just know that most infections are really, really rare, so it's not a super high yield thing to know, they're just rare. O positive is the most common, and it's nice for us because if you take O positive and you turn it like this, it's the sign for female. So it helps us remember the most common is O positive. CMV is actually very common in the adult population. Literally 3/4 of us or more have been exposed to it by the age of 40. So therefore we don't screen for it in our blood supply all the time. However, we do have a small population of CMV screened blood always available for immunocompromised patients and those that are just like that, which they are, pregnant women. Primary care and causes of death by age. It's usually good as a doctor to know what's going to kill people and try to stop that for them. That's what's up top there for you. There was a slight change in this. It used to be super easy, but there's now this breakup between 35 and 44 and 45 and 54 where things switched around a little bit. Remember that accidents does not include suicide or murder. That's only going to be including accidents of other forms. 65 and older, that cardiovascular is up top, but it also moved up in the 45 to 54 range. Cardiovascular is becoming more and more of an issue for female patients, and therefore is a higher and higher concern for ACOG and other organizations that work with cardiovascular disease. So if I were you, I would make sure I understand things about cardiovascular disease and what could make it worse and what risk factors could be present. Immunizations are there for you, and I'll talk about pneumococcal in a second. Don't worry, I'll walk you through it. It's not that bad. But some things that I would consider is UAs really aren't a big thing anymore. So it depends on who you read, but USPSTF, who ACOG tends to endorse, does not think it's a thing, and you shouldn't really be doing it unless you have a risk factor for it. Also, stop testing thyroid hormone, smacking the hand from the endocrinology world. No more testing thyroid hormone. We overtreat it, we over-test for it, and a lot of times patients don't need anything for it, but we think it's the cause of everything, right? That's what they think about us. So that TSH is not a recommended at all times thing like it once was. If you haven't checked it out before, you should check out WPSI.org. This is the WIPSI project. WIPSI is Women's Preventative Service Initiative. This is where the nurse practitioners, the CNMs, the midwives, the internal medicine, the pediatric folks, and us all got together and said, why do we do primary care for women differently? We should stop that. We should all do it the same. And that's when ACOG entered into the WIPSI project and agreed that we would all do it the same. You go to WIPSI.org, you can actually order a really cool, nice chart for your office that's all laminated and pretty and tells you everything you need to do throughout the pregnancy. Metabolic syndrome is one of my favorite diagnoses. I talk about it quite a bit, but you need those 3 out of 5 things in the metabolic syndrome to diagnose it. You need that blood pressure that's weird, the waist circumference of greater than 88, which looks like 2 people standing together. So if you need a belt for 2 people for 1, that's not a good thing. HDL being low, because remember, HDL is hold on to, because it's the nice one. fasting blood sugar greater than 100. Remember, it has to be a fasting blood sugar, and someone at risk for metabolic syndrome or that has the diagnosis, you're going to encourage them to exercise and run faster, fasting blood sugar. Triglycerides greater than 150 are also a risk factor for metabolic syndrome. 3 out of the 5, you can diagnose it. Let me remind you to leave LDL out. It is never the answer. 50, 100, and 150 are the numbers. You just have to put them in with what they belong with, and you should be able to figure that out. Let's go ahead and jump down to SIGE-CAPS depression screening. I'm just going to tell you, you need to know what SIGE-CAPS is, and you need to know what it stands for, and what components are there and what components are not. Pneumococcal. People always panic about pneumococcal. I've talked to tons and tons of internal medicine folks to help me make sure that I understand pneumococcal, and guess what they told me? It's not that bad. Right, for them, but let me show you it actually isn't that bad. First and foremost, anytime someone is given PCSV 13, they're going to get PCV or PPSV 23. So if they're getting PCV 13, your instant answer is going to be, they're going to get something 23. Because it doesn't matter where in the schedule they are after that, it's always going to be 23. And it's not a great question to ask about 23 and then put 13 after it. Let's talk about 2 of the schedules otherwise that start a little bit differently. That's going to be this naive adult up here, which can start with 15 or 20. After that, in 8 weeks, they're going to get PPSV 23. So 15 and 20 can start either way. If they get 15, they got to get PPSV 23. So there's 13, it gets 23. 15, it gets 23. Let's keep looking at these and making sure we can make sense of them. Down at the bottom, there's 2 flow charts there. They both start with PPSV 23. So this is how I organize them with the numbers going up in my brain. So 13, easy, gets PPSV 23 all the way down. Then I get to my 15, which there's a 20 escape route where I can just give 20, and then I don't need my 23. So if I give 15, I need 23. Or I can just give 20, and I don't need the other 20, 23. Now, if I start with 23, I know there's 2 ways to go, but both of them are going to end up just reverse of this one up here. So if I remember those 2 at the top, the naive adult and the 65 and up, and I can get those locked in, all you're doing is taking that top one, flipping it over, and it's the same thing, just backwards. So just remember, it's not as bad as it looks. It's actually pretty simple. Walk through it a couple of times with me, rewind and listen again, and you'll get it. Hepatitis V virus testing, I'm just going to point some important things out to you. When it comes to these individuals and figuring out these test results, you just need to remember 2 big things. When it comes to acute infections, there's only one of them that has it. It's IgM is acute, and it's only the acute form that will have IgM. If it has an IgG, it's going to be one of the C forms, and there's 3 C forms. That's going to be your chronic, your carrier, and you're cleared. So all of those will have an IgG. So you're down to at least 3 of them. And when it comes to those, you just have to look what's missing and what's there, and it helps you out quite a bit. Headaches you have to know, but I'm just going to tell you to not forget about thunderclap headaches. That's the sentinel bleed of an intracranial aneurysm and something you should be able to recognize. Asthma is by FEV1. Just remember, people get confused by the terminology because they get these all mixed up and they put intermittent where it doesn't belong. Intermittent is either here or it's not. It doesn't need any other classification. It's here or it's not. It's intermittent. But if it's persistent, I need to qualify how persistent it is. Mild, moderate, and severe. And if nobody ever told you, mild and moderate, mild comes first because it's an I, and moderate comes next, which is O. So moving upward, least to worst is mild, moderate, severe. You can see the FEV1s help you predict which type of asthma you're looking at. And as far as treatment, the first 2 or 3 steps of that treatment table that looks like a stepwise program, that's what you need to focus on as a generalist. Step 1, 2, and 3 treatment, which gets you up to about moderate and a little bit of severe persistent. But after that, you're getting some other folks involved anyways. Sleep apnea is becoming more and more of a topic as obesity becomes more and more of a problem in the United States. We're also seeing sleep apnea in children now. Neck circumference of 43 centimeters or less is a low probability of sleep apnea. Also, they may have problems with sleeping throughout the night. They have daytime sleepiness. They have habitual snoring. Hypertension is also a big one to look for. Fracs. The answer is never menopause. Please don't pick it. Fracs can be done for males, females, and everything in between, so menopause is not the right answer. It's your risk of osteoporotic fracture in the next 10 years for that patient. It does include things like age, sex, alcohol, steroid use, smoking status, and it's only telling you that you should consider treatment. You don't have to, but you should consider it. If it's greater than 3% risk of hip fracture or greater than 20% of major fracture, and I just remember 3% goes with just the one thing, the hip, and the 20 goes with any fracture because it's more things, you should be able to remember it. Also, you got to know your T-score system. Remember, we're calling it low density, not osteopenia anymore because people got things confused and they thought they had the worst or the less severe and they were off. I would make sure I know these medications. Osteoporosis is something that we definitely take care of. So therefore, I want to know if patients have risk for it for taking certain medications throughout their lifetime. Let's jump into gynecology. This is a great differential table to help you with things like labial masses, vulvar ulcers, vaginal lateral masses, because that's a hard one that people get wrong. And then also down at the bottom page, there's some things about Depolupron. Remember, Depolupron is pregnancy category X. Depolupron is an agonist of the GnRH system. It loops it up. It turns it over and over and over faster and faster until it just stops because it's GnRH. It has to be pulsatile to make HPO access work. So that's the agonist and it's going to loop it up. And as it's looping it up really fast, that's why you get the flare effect so badly with Lupron. Now, remember, we also have things like elagolix or Alyssa now, which is our new and fancy GnRH antagonist. The antagonist shut down the GnRH system directly up in the top of the hypothalamic pituitary region. This shuts it down quicker and faster, so we have less of a flare effect than we do with Lupron, but it can still be present. But again, both of these are considered pregnancy category X or problematic, and these patients need to be on birth control for at least the beginning treatment if they're not shut down completely. But actually, both manufacturers recommend they need to be on birth control for the entire treatment period, as these are not birth control forms or contraception, and getting pregnant on them could increase risk considerably. Now, on the antagonist, it is specifically stated in all of the literature that they should not be on a hormonal form of contraception, as it increases risk for thrombosis, stroke, and heart attack. Hot flushes, we always want to just jump to menopause and think it's those vasomotor flushes. However, we know that there's many other things that can cause them, so don't forget these and run right at menopause and get the question wrong. These are the folks you don't want to give HRT to. I would probably know that list pretty well. Top-Q and Bader Walker, it's not that bad. You just have to learn what's in the table and then know that this is the top part of the vaginal canal, so cystoceles and urethroceles, and that C is continuous. It'll always be there. It's the cervix or cuff, even if you do a total hysterectomy. The bottom is going to be the posterior. So this is the back part of the vagina. And that's going to be things like enteroceles, which is at BP, or rectoceles, which is at AP. D disappears when you do a total hysterectomy because it's the posterior fornix. The fornix is no longer there if you don't have a cervix. So D disappears. This middle part is kind of your continuity measurements. Your genital hiatus, which is the most measured the same between interrators. So if I measure it, if you measure it, if anybody measures it, it should be the closest measurement that we all get the same. Perineal body, we've all put enough of those back together and know what that is. And then TVL is total vaginal length, which has to be measured at rest in a supine position to give them the maximal length possible for measurement. Vascularity is covered extremely well in the Obgyn Illustrated Guide, but I will also point out to you here that you need to know vaginal lymphatics and vaginal arterial supply. These are hard because they're not pointed out in a lot of the text, but they're important for drainage of disease like infectious things or cancer. The upper third of the vaginal canal is to drain to the iliacs. The middle third is to the hypogastrics, and the lower third is into the inguinal. Nerves to the uterus are hypogastric plexus, which a lot of people forget crosses over with the ureter over the common iliac, bifurcating into the external and internal iliac. And that's a good one to know anatomically. This also gives to Frankenhauer's plexus. And when you're messing with somebody's cervix in the clinic and you've done a cervical block and they're all of a sudden feeling intense pain while you're doing cervical things, they're probably going to pass out next. This is going to be the vaginal vasomotor syncope. So that is connected to the sympathetic responses in Frankenhauer's plexus or the hypogastric plexus. And all you need to do is put them in deep Trendelenburg, get some blood flow back to the head. You may need to do fluids. And in the very, very rare occasion, they may need atrophy to bring that heart rate back up. Levator ani. It's the iliococcygeus, the pubococcygeus, and the puborectalis. We came up with this cute little saying of I see Puerto Rico on the PC. A lot of people put their background on their computer screen to be a beautiful tropical place like Puerto Rico. So I see iliococcygeus, Puerto Rico, puborectalis, and PC, pubococcygeus. Never, ever, ever pick iliacus, coccygeus, or piriformis. These are not part of levator ani. I just remember levator ani likes to work as a group. It's a group effort. It's a team thing. So everybody that's part of it is also in a team. They have two things in their name, iliococcygeus, pubococcygeus, puborectalis. Teamwork makes the dream work. And the pelvic floor. Ulcerative lesions can get pretty confusing, so we've kind of laid out as much as we can out here for you in one table to make sure you know what you're looking for. The things that are bolded are the things that are very specific to those different things and should help you identify them accurately. Hey, take a look at syphilis testing. You may not do it this way at your institution, but this is the CDC way, and this is the ACOG endorsed way. So make sure you're doing it this way. This starts with non-treponemal testing like RPR or VDRL. This can be negative in a screen, which is no disease. If it's positive, then you got to get real specific, right? So you're going to do an actual treponemal test. That treponemal testing is TPPA in most institutions now, or FTA testing. If it's reactive, this is disease. If it's negative, it's disease unlikely, but also can be a false positive. So further testing may need to be monitored. This is a great listing of a couple of pages of lower genital tract infections and all the things that go along with them. This is a very useful study area to get into some things that are kind of rare to be asked about, but at the same time, you need the information there. At the end of that, we've broken down syphilis for you, making sure you understand the treatment of the different parts and forms. And also remember that when you're treating somebody with HIV or immunocompromisation, that's going to be an aggressive treatment than somebody who just has unknown treatment, timing, or whatever else. Small bowel obstruction versus ileus. Let's do the biggest and most important things. If I was writing an exam question regarding obstruction, I wouldn't go with a partial. It's confusing. It's too gray. It's not easily one wing or another. So I'd go with a complete versus ileus. Complete will not have air in the rectum. Absolutely no air will be in the rectum on a fair question regarding an obstruction. Ileus, there'll be air in the rectum. That's actually the most important part. I don't care about all this fluid levels and air and all those kinds of things. They're important, but this is what tells you in a question whether it's right or wrong for obstruction or ileus. This is our little mnemonic for what you look for on a CT scan for obstruction. It's draft. In the workup below, just make sure you understand how to work one of these babies up, because if you're on an oral quiz a little bit later after you pass this written quiz, you have to make sure you're not just taking people to OR because you think you have an obstruction. You need to make sure you're working it up the right way and seeing the things that you need to see to make sure you're doing the right thing for the patient. Because you can also take them to the floor and be conservative in your management. But I will tell you, if there's leukocytosis with the left shift, you need to be in the OR. Now, something that you might recognize is a little bit different from some of the books is this 5 days of waiting versus 3 days. ACOG and most of its literature leans toward references that state 72 hours is the max time that you should really be waiting to see if something's going to resolve with an obstruction or not. 5 days of waiting can result in risk of obturation, impaired bowel function, and mortality. That used to be the standard 5 days, and some surgical texts still refer to it that way. But most of our literature review has pointed to 72 hours being the max that you want to head out and just do surgery anyways. Reproductive endocrinology. Karyotype abnormalities and sexual differentiation drive some people just absolutely nuts. We've tried to make them as easy as possible for you and put them in quick and fast tables for you to figure out what's something that makes one different from the other. Hyper, hypo, and hypo are things that you break down versus genetics and labs. And these are different ones that you can differentiate pretty easily. There's also a great image in the Obgyn Illustrated for primary amenorrhea that makes it fast and easy for exam answers. But remember, not everything's considered there. Here's some more karyotype syndromes and things that lead to infertility. And then also let's look at the ovary versus adrenal for the hormone showdown. All I'm going to really point out to you here is DHEAS. DHEAS is only made by the adrenal gland. The adrenal gland is the only thing that likes to sulfatize the things that go through it. So if you see something like a sulfur on the end, that's going to be an adrenal gland hormone, and that's DHEAS, which it makes it 100%. Also remember, this is the strongest form of androgen, which is DHE, dihydrotestosterone. Below that, everything else is just a tad lower, TAD. So going from strongest to weakest, it's DHT, testosterone, androstenedione, and then DHEA, and then DHEAS because it's been sulfatized by the adrenal gland. Ovarian hyperstimulation syndrome, I'm just going to grow you to this point here. VEGF, IL-6, and IL-8 is what's produced by the multiple corpus luteum that are left behind after we produce multiple follicles from gonadotroph stimulation. Remember, this can also be caused by a benign hamartoma. It does not have to be all IVF. We don't have to blame IVF for everything, everybody. So it can also be a benign hamartoma. But these things are what lead to all of the pathology problems that you have to treat, watch for, and make sure aren't happening for patients with ovarian hyperstimulation syndrome. Cholesterol synthesis is detailed in the Obgyn Illustrated, and the Obgyn Illustrated video will take you through the cholesterol pathway that is going along with this table. But we put it here for you as well too, so that you could take notes on it or study it how you would like to. Primary amenorrhea is another thing that just makes some folks just not happy. And it's a topic that we broke down for you here. And these are things that look at anatomy. So anatomy is going to help guide you to what you're going to do next and what tests should be done. Remember, a uterus is a big piece of that. If the uterus is absent, it takes you down a whole different pathway versus if the uterus is present or not. This is primary amenorrhea continued here. So again, things to look at. We continue on at looking at more of our gonadal dysgenesis problems and other issues that may happen related to other metabolism or cholesterol synthesis pathways. All right, polypeptide hormones. These are going to be prolactin, growth hormone, and human chorionic somatomotropin, or HPL, human placental lactogen. Now, I'm going to tell you right now, this one is made by syncytiotrophoblasts. So syncytiotrophoblasts are producing that HPL. That's why I want you to know that it's HPL, because that kind of links it up to the syncytiotrophoblast. Now, glycoproteins, I like to remember those freaking like hormones are freaking pests. That reminds you that all of these hormones are linked by a similar alpha subunit and can interact with each other's receptors and cause outcomes like the other hormone can, such as beta-HCG drives up TSH reaction in the pituitary and hypothalamic area during the beginning of pregnancy, and that's how we end up in euthyroid state in most healthy individuals. Gynecology, oncology,